We will proceed to the next session, structural interventions. The chairperson for this session are Dr. Anil Singhi, Dr. Saroj Mandal, and Dr. Shamik Basu. The moderator of the session will be Dr. Anil Dhal, and the expert panelists are Dr. Subhashish Roy Chaudhary, Dr. Devjyoti Sarkar, and Dr. Priyam Mukherjee. I will request the chairperson and the moderator to take over the proceedings, please.
So I think we are a little behind time, and we are here with you, Dilip, and I can see, Ramesh, it must be early morning. You're looking very nice and bright. So I guess we're not going to do much ado and go straight on with the job. I can see Ajay looking very philosophical, but we will get on with mitral valve interventions. And since Ramesh is looking so bright and it is his talk, over to you, Ramesh. Ramesh doesn't need any introduction. So he's one of us, and who has always been quarterbacking every academic cardiac activity in our country. So over to you, Ramesh.
Thank you very much. A great pleasure being with all of you. And I see Dilip, thank you for giving me this opportunity, and Suneep, and also the entire organizing secretary, Dr. Debabrata Roy, and our leaders, Dr. Kali and Dr. Manoj, and all the ICON, EIC CEO, and organizers. So today my topic is on mitral valve interventions, and we had a wonderful talk on TAVI, and let me share my screen, and we'll go very quickly on our path onto mitral valve interventions. So let me see, 1 minute. You can see my slide, my screen still, or?
Yes, we can. You just have to go to slideshow.
Okay. Are you seeing? Is it okay?
Yes, Ramesh.
Okay. So mitral valve interventions is, it's nothing that we need to greatly learn about, because India has been in the forefront of treatment of mitral stenosis for the longest time, and where now hopefully the rheumatic heart disease incidence is coming down. And but mitral stenosis has been the stay of, the mitral balloon valvuloplasty has been the stay of mitral valve therapies in most countries in the 1970s to till now, and we still use this same balloons in all over the world for mitral stenosis. So as you can see that the first successful surgical mitral commissurotomy was performed in 1920. Inouye balloon was performed in 1982, and we still use that to date. And first MitraClip was actually FDA approved in 2013, and the first TMVR in MAC also was performed in 2013. I started using MitraClip in 2009 in part of the clinical trials, and we are also very active in the transcatheter mitral valve replacement currently. Mitral regurgitation has been the mainstay of mitral valve therapy. So there are two types of very incompetent mitral valve closure with the systolic retrograde blood flow from the LV into the left atrium. And it's a primary is if there's a valve morphology abnormality, whether it is in the leaflets, subvalvular apparatus, or chordae and papillary muscles. Secondary mitral regurgitation is due to LV dilatation, often due to ischemic heart disease, and leads to mitral annular dilatation and incomplete coaptation of the mitral valves. So the most important part is that there is, understanding mitral valve is a very complex structure. It is very heterogeneous. It is not the same. And current options are always inadequate in the mitral valve therapy. So whereas TAVI, in my opinion, it is something simple, but yet it is very difficult to treat, in the sense if a complication happens, it is really a very drastic complication, and it's almost like acute MI. If you think acute MI, aortic valve stenosis is our treatment of that is like treating an acute MI. Mitral valve is almost like treating a stable ischemic heart disease, because complications are still very low, even though it is very challenging to understand, and the asymmetric nature of the mitral valve, the landmarks are not very clear, closing pressures are higher, but still the complication much lower than the TAVI. So And if you look at the opportunity to treat and the business side, if mitral and tricuspid alone together, they will probably have about $20 billion business in the future, whereas aortic valve is only about $5 billion in business. So that means that so many patients will have a mitral and tricuspid valve problems. So this is in 2009, one of my first patients, and I always show this, that severe mitral regurgitation, 84-year-old man, deemed inoperable by 2 cardiac surgeons at that time. We needed that as part of the Everest trial. And 2 hours later, from skin to skin, we were able to reduce the severe mitral regurgitation to more like mild to moderate. And any improvement of 2 grades from severe to mild to moderate is considered as a positive. And the patient really was suffering from heart failure admissions for the past few years. He enjoyed his life for the next 5 years, and a natural death happened at that time at the age of 89. And so rewarding to see that there was a difference in the patient's lifestyle that could be made with this MitraClip. There are several devices. Half of them will not see the daylight, I think. And as you can see, only one of them is approved in the United States. It's a MitraClip. And in trials are actually Pascal, as probably will come to United States soon for FDA approval. And there are so many other things that maybe some of them will, like Millipede and MitraSpan, might see some light. And there is a Half Moon Medical that is also looking at both the mitral and tricuspid space as well. Caudal repair, enhanced coaptations, LV remodeling, and indirect or direct annuloplasty are all in clinical stages of trials, and we'll soon learn about that. So why is all these companies coming into treatment of mitral regurgitation is because the 5-year results of Everest 2 showed that treatment of primary mitral regurgitation with the therapeutic, with MitraClip versus actually surgery did not show any difference in mortality. It is somewhat similar. The mortality at 30 days is 6%. And so there's no difference between device versus surgery in the Everest 2. And then we also had another trial for functional mitral regurgitation called COAPT, in which we were participated as well. And that actually showed 600 patients were randomized either to MitraClip alone, MitraClip with the guideline-directed medical therapy or guideline-directed medical therapy. And this actually was a heart failure trial, and which showed that all hospitalizations for heart failure within 24 months was significantly reduced with an absolute risk reduction of actually of nearly 40% in heart failure readmissions. And not only heart failure readmissions, but also there was a mortality difference between MitraClip versus guideline-directed medical therapy alone. And as you can see in the device group here, the mortality is about 23% at 2 years, whereas control group guideline-directed medical therapy, mortality is about 44%. So there's a 20% absolute risk reduction here with in death with MitraClip alone. But there is a discrepancy between COAPT trial, which was performed in the United States, versus a MITRA-FR trial. And I think it is mainly because optimization of medical therapy was actually maximal in COAPT by the heart team. And the smaller LV dimensions, essentially, we did not choose people who already had baggy left ventricles. So they were very much not end-stage cardiomyopathy. And use of more than one clip was performed in COAPT. MitraClip performed at specialized centers in COAPT, actually very clinically, very chosen clinical centers. And 35% had moderate MR in MITRA-FR as compared to most of the people who only had severe MR in COAPT trial. And more complication device related and the residual MR in MITRA-FR and very high risk population in MITRA-FR as well. So you need to select, patient selection is quite important. Such a patient with all these degenerative mitral regurgitation, not everything can be clipped. And these patients probably have to be thought of whether they can undergo surgery. And if they cannot undergo surgery, is there a transcatheter option? So the advantages of repair in a surgical world always have been preservation of heart function, freedom from lifelong medications, longer durability, and better chances for survival at the time of surgery. So, but however, all of them cannot be repaired by catheters. So we might have to think about replacement. And this is how, at least in my experience, we started thinking, okay, 59-year-old woman with shortness of breath and had a repeated mitral valve replacement, so initially repaired, then a replacement and by Edwards mitral valve. And she was admitted with heart failure with a cardiac index of 1 and severe mitral stenosis and mitral regurgitation with as a leaflet shows a perforation. And in 2012, after being in a partner trial, and so we did a transapical TAVR valve in the mitral position, and this patient actually did quite well. And as you can see, the leaflets are opening now, and there was no regurgitation. And her cardiac output was 1 liter pre-procedure, went to 5.2 liters from class 4 to class 1. This was completely off-label. The hospital had to eat the cost because she was admitted and she was not being discharged. And so we just gave her a free valve so that we can at least able to discharge her home. And we did that. And then 2019 in India, we did this actually as a live case in Chennai, where we used my valve in the mitral position, now completely changed from transapical to transeptal, and being able to do it very quickly in half an hour. Along with after the live case was done, she had a paravalvular leak from a suture that came off. So we did that plug of the paravalvular leak as well. So what anatomic criteria preclude repair with MitraClip? You know, we always try to see whether we can repair it, similar to surgery. If not, maybe a replacement is required in such patients with calcification of the clefts in A2 and B2 scallops, severe MAC, mitral stenosis with an area of less than 4, flail width of more than 15, flail gap of more than 10, commissural mitral regurgitation. Even though now I have done a few of these in the MitraClip, I don't think you always have to go for replacement, but be careful when you start MitraClip in commissural. You need to make sure that you don't get caught in the cords, and that is really problematic that can happen. And too much redundant leaflet tissue or coaptation length more than less than 2 and depth more than 11 millimeters, there is a need for a replacement therapy. So here is such patient, 66-year-old man with bypass surgery, AVR in 2014, TAVR then in 2019 for failed bioprosthetic surgical valve, and type 3B Carpentier MR with multiple admissions for heart failure. So this patient comes to our center, and we discussed and we enrolled her in the SUMMIT trial, and which is a 10-9 trial for mitral regurgitation or in MAC. And so this patient, this is the valve that comes up, and once it is deployed, there is absolutely no regurgitation at all. And so this is in functional mitral regurgitation. So this is how the patient is. You can see there's a surgical valve, and there is a TAVR Evolute Pro, and then we had a Tendyne in that place, and there is no MR at all. And you can see nice CT pictures, which is just for not to, nice picture, that's all. There's nothing that it's showing. So how about in MAC? 84-year-old woman, and even today, just now, I saw another 85-year-old woman who probably will go for both the TAVR and the Tendyne later, and severe MS and MR, and the MAC is, you can see that very bad in this patient, and we performed again a Tendyne, which is done by a small transapical approach with the cardiac surgery on board, and in the future this might become transeptal, but we had great results. We have done so far 14 patients. We are number 4 in the country to enroll patients in the SUMMIT trial. SUMMIT trial is actually going to be looking at Tendyne versus the MitraClip for severe mitral regurgitation, but people with MAC will only get a Tendyne valve. And several mitral valves replacement devices are going to be coming into the picture. 12 Medtronic and M valve, and Edwards is doing their own replacing those trials. But unfortunately, some of them like Tiara, they are not going to come into any picture anymore. They are the first ones to start off with. And so Tendyne is what we use because it has a nice mitral valve, and it can be tethered to the left ventricular apex, and you can loosen or tighten the mitral valve, how much it is sitting in the annulus, and make it a little bit stronger or have less leak. And if you tighten too much, it might actually create a LV systolic dysfunction. So you have to be careful in that. But that said, all-cause mortality in Tendyne here has been the lowest compared to all the others. And so I think, Tendyne probably from a Summit trial will have slightly better outcomes in the future. We have to wait and see. What is the strategy based on mechanism and pathoanatomy of mitral regurgitation, valve replacement to actually annuloplasty and leaflet repair? I think if the valve size is less than 4, go for valve replacement. If it is between 4 and 5, go for clip, and more than 5, go for annuloplasty and leaflet with the clip. And with apical tethering in functional mitral valve disease, you can do valve replacement similar to less than 4, and or even up to 6. Actually, you can go with valve replacement, and in between you might have annuloplasty and leaflet repair. So we still have to wait and see if this is going to see the daylight as annuloplasty and leaflet repair as a combination. So my take-home message is mitral valve interventions is a natural transition from a transcatheter aortic valve replacement. That's where we got our ideas from, right? And the MitraClip cannot treat all patients. And knowing anatomy of the mitral valve helps in choosing the right therapy. And the Summit trial will show whether leaflet repair with MitraClip or replacement with Tendyne is better. And repair MR trial is part of one of our trials that we are doing. It will show if MitraClip can be used in intermediate risk patients as compared to actually surgical mitral valve repair. Thank you very much. I'll stop sharing and I'll be more than happy to take any questions.
So that was truly brilliant, Ramesh. As always, you did such a complex, the mitral valve is such a complex structure. And that's why we don't have a one-size-fits-all solution for it. You have the cusp, the chordae, the commissures, the papillary muscles, and it's a very complex anatomical structure. So if there are any questions from the chairpersons or the expert panel, we will hold Ramesh to try and answer them. If not, may I just request Ramesh to say the differences between COAPT and MITRA-FR. Do you believe in the concept of proportionate versus disproportionate mitral regurgitation, which Paul Rayburn and Milton Packer had kind of suggested? And
yes.
that would probably explain some of the features as to why we could take some patients for mitral valve therapies and why we should not take some.
Yeah, absolutely. I think, Anil, you nailed it. And it's, how much of them are proportionate MR, and, patient selection is very important in this group. And nowadays, people have started looking at actually cardiac MR to assess severity of mitral regurgitation, and also to see what is the myocardial remodeling that has happened. And if they can, if there is some remodeling that is already very chronic, fibrosis, you are not able to make those people may live longer or feel better. But if there's no fibrosis on the myocardic MR, and those people actually do better with MitraClip.
So great, thank you very much. And I think there is going to be, if there's any question, we'd welcome them. Otherwise, we'll thank Ramesh for a brilliant talk, and I'll move on to Ranjan. And we all know that Ranjan is a dashing young cardiologist who's pioneered left atrial appendage occlusion devices in the country. And it's my great privilege to introduce this very brilliant young man. And he's taught us all left atrial appendage occlusions, and it's John Manrola part. Let's get away from the controversies and hear some of the tips and tricks.
Thank you, Dr. Anil, and thank you, the organizers of ECCON. And there are so many familiar faces on the panel. It's good to see all of you. And I think that today's the talk is more about whether MitraClip, whether the LA appendage closure has really delivered what it's supposed to deliver. Did it fail us, or did we fail it? That is the way I'm going to put it, and that's the way we are going to discuss. So we know AF is a very common problem, and it's something which is going to be there, and it's something which is going to increase. Fortunately, there is a good therapy which is in the form of drugs, which are now available. You have oral anticoagulants. You also have what we call as a direct oral anticoagulant. But the problem is the people who cannot take, people who do not want to take, and also there are lots of hesitancy from the physician's point of view. Most physicians also are, the disease gets undertreated and the anticoagulation therapy doesn't reach everybody that they need it. So that is why we need an alternative treatment, and we need to decide which of the subgroup of these patients where we are going to use the alternative treatment. When we were using oral anticoagulant, which was WARF, we realized that very few of our patients in real world are actually in therapeutic target, and it becomes difficult. Less than, in trials, it is 1/3 who are not in target, but in real world, the number is still higher. And especially when you talk about an 80-year-old who is very fragile, whose mobility is restricted, this therapy becomes still more restricted. And the drugs like statin, which are known to be very, very effective in CAD, gets underutilized, and people do stop these drugs after some time. Imagine telling somebody 70-year-old that you need to take these drugs for lifelong. It becomes difficult for them to do and manage. So these are all the challenges. So the first question is there a mechanical alternative? The alternative for so-called non-valvular AF, that means AF not produced by mitral stenosis or a prosthetic valve, by definition is a non-valvular AF. So if it is MRAF or if it is a ASAF, HOCM AF, they all fall into so-called category of a non-valvular AF. In these, more than 90% of the clot actually comes from one particular area, which is the appendage. And if you can successfully close it without too much complications or too much problem, then you can effectively limit this disease, and then just the antiplatelets are enough and you don't need anticoagulants. So this is the rationale. Now the question, especially for today's talk, is the evidence. Is the rationale enough, or do we have any evidence to prove this? Therapy has been there for long. Plateau, the device which is old, was being there from 1990 to 1991. And there are numerous other devices which are available now. But the trial is actually only with Watchman device. And there are two important trials which we may have to quickly run through. One of them is the PROTECT AF trial, relatively big trial and showed very promising result. And the second is the PREVAIL trial. Then there are registries, which is called Evolution Registry, CAP Registry, but we need to talk about a little bit about these two trials before we understand. So talking about PROTECT AF trial, it was a multi-center trial, which was done, where LA closure was compared to, with Watchman device, was compared to warfarin in 2:1 design. And it had its own protocol, 45 days post-implant, because endothelization is not complete. They wanted people to take warfarin. And beyond that, if there is a peri-device leak, they still wanted people to take warfarin. So what it showed, that when the device was put, the success at that time was only 95%, because most people were still learning how to use the device, and this is too low compared to the current era, where the device success with Watchman itself is 98.5. So it was 87 to 90, but even with that, when there was a 3-year follow-up, the intention to treat analysis did show a result which was favorable to Watchman, and in 4 years analysis, it actually showed mortality benefit. If you look at this data and compare to the, if I can be a little more bold in saying that our coronary angioplasty for a stable coronary artery disease does not have this kind of data now, where there is no mortality data. Acute is different. For stable coronary artery disease, the data for a CAD is much lesser than what we have as far as a Watchman device is concerned. Naturally, it did show decreased hemorrhagic stroke. It also was superior, event-free survival was superior. And when they did the 4-year follow-up, there was actually mortality benefit, which was actually favoring the Watchman device. Hemorrhagic strokes were less. So overall, it was a favorable device. And in summary, it was a randomized trial which did show that stroke and all-cause mortality were initially non-inferior to warfarin in 3-year study, but in 4 years, it was actually superior to Watchman. Then came PREVAIL trial, because the PROTECT was not enough for US FDA to give permission. So they didn't get the permission. So they wanted a US specific PREVAIL trial, which again had almost the same inclusion and exclusion criteria, but it was done more in US. And the results technically were comparable, but if you see that the efficacy rate of both Watchman and Warfarin match, and it was comparable, but statistically it did not become non-inferior because there was a wider the interval which was present. But with time, the procedural success had improved. From Protect AF, the success was 90, became 95.1. And as I was telling, today's era, whatever device you have in your shelf, your procedure success is typically 98.5. That is because we have understood the device, we have understood how to close with different anatomy. Now, this was our first experience which we published. The evolution resultantly also mirrors this. The point I want to just highlight is not to go through this data again, to look at what are the indications globally today. How are we using? So what we realize now is what we have discussed is the therapy which could be used as an alternative to oral anticoagulant, especially warfarin. But worldwide, if you see that it is actually indicated in people for whom the therapy, the anticoagulation is, contraindicated, or people who have bled. This is the worldwide data. So only 1% of people have it's been used as an alternative to anticoagulation. This is the data from Europe, where the device is available and device can be used. And in US, the indication is little different. There it was for people who could take anticoagulation just based on the Protect, but who did not want to take, or where physician felt the patients are at high risk. So there is with this therapy, when you see the problem is opposite. You have data on one end for as an alternative, but world over it is used where it is contraindicated, and you only have registry data in that subgroup where where it is contraindicated. It is just the registry data which is there. So, but if you look at the categories where it could use, we could use it as when people who have already bled on oral anticoagulant. This was the extrapolation of a Protect AF data, but there is no randomized trial in this category. It could also be used in people with high CHADVAS, but also high has bled, but who have not bled. It could also be used as an alternative to oral anticoagulant. That is where the data lies. There are 5% of our patients who are on oral anticoagulant, which could be the best of the direct oral anticoagulant, but still have bleeding, still have strokes. We could use them there. And it could also be used as a part of AF ablation to prevent at least the stroke risk. It could also be used in people like CKD, CLD, who are otherwise extremely high risk and who cannot tolerate any direct oral anticoagulant. So overall, world over, the geography world, the indications have been varied. I just discussed the US indication. So just to summarize in time, the point what we are trying to make is whatever indication you choose, as physicians, we do see a lot of AF, maybe 5, 10 a day or maybe more. But whatever indication we choose, all of us have some patients who require this therapy. If you have taken it as alternative, obviously there are too many patients, but even people who have bled, people who have had problem with anticoagulation, all of us do have some patients who need this therapy. So all of us need to learn this therapy. And I feel the key point, what I feel here is, I think we have failed the therapy rather than the therapy has failed us. Thank you, Dr. Anil. I'll be happy to take any questions.
That was brilliantly put across. You've weighted the problem points and all the data very, very astutely and with a lot of diplomatic finesse. I must compliment you, so that you not got into any of the gray zones. So Ranjan's talk is open for any questions. And I just have one question, and that is that you say we have failed the therapy, but do you think the therapy and the tools available to us insofar the therapy is concerned are still perfect, or we are still in search of the Holy Grail? Yeah. Because we don't really, we have wide disparities between the offerings that we have, and we don't have anything which is perfect. And despite therapies, there have been failures. So just your comments on what do you think would be an ideal left atrial appendage occlusion device?
Yes. Thank you, Dr. Anil, for raising it. Now we have 4 devices which are available in the country and all are DCJ approved. The point is at one point, the people would, because LA anatomy varies too widely, and it's very difficult for it's not like coronary. You can't decide I will do only a type A plasty and not do a CTO. Here you don't have that choice. Once you go in, the anatomy could be varied and you may not be able to predict. But luckily for us, now whichever device you have in our shelf, 98.5% of LA can be closed, whether it is Watchman, whether it is Lambre, or whether it is ACP. So that means we fail in a very, very small percentage of cases now with the current LA devices. Yes, among them, maybe Lambre will be more suitable with number of offers available. The success could be 99.5, but hardly ever we fail to close LA effectively. By close, I don't mean, leave a gap here and there. Most of the time now we are able to close almost all LAs effectively.
All right. So thank you very much. If there's any other question, Ajay, would you like to ask a question? Anything specific? Dr. Kali, hi, how are you? Any question?
Great talk,
I
Dr.
was
Ranjan.
looking at the slides.
please
He
go
has
ahead.
given a beautiful lecture. Congratulations, Ranjan. How do you feel that the cost prohibiting factor, how does it affect? Because you are the person who puts the maximum number of this appendage closer device, and that too with lot of precision and with a very high success rate, with a very low complication rate. So how do you find that with this socio-economic condition in our country, how feasible is the device?
Thank you, Dr. Kahali, for asking that question. So I think here, if you look at cost analysis, it actually, there are economic analysis which says it favors LAA compared to a NOAC therapy, but then it has to be used for little younger patients, in the sense you can't wait for 80, 85-year-olds and then put and hope for an economic analysis. But you look at a patient who is 65, 70, who is likely to live, say, 10 more years, and if you calculate that they are supposed to take one of the newer drugs for 10 more years, and also the fact that there is 2% bleeding risk per year with any of the device. So in 10 years, the bleeding risk could be 20%. So it makes more sense. This is supposed to be like an immunization. You put it once, even the patient cannot pull it out. So over the period, over 3.5 years, both in Western and our data, it actually becomes cost effective.
Very good. Excellent.
Praveen, would you like to say something?
Yeah, I have a question, Dr.
Yeah, Dilip.
To Dr. Sethi. I think it was an excellent presentation. Like, do we have any data with LA appendage occluder devices versus NOACs? So all the trials have been done with, warfarin compared with warfarin. Do we have trials versus NOACs, LAAC versus NOACs?
Yes, not at Dr. Dilip. That's a good question again, but there's an AMULET trial which is done against, there are 2 AMULET trial which will be available soon. One, they are comparing AMULET versus Watchman. That's for US FDA approval. And there is an AMULET trial which will be done against NOAC. So we need that data before we elective, because before we claim superiority. But even with NOAC, there is bleeding risk. That is, I mean, most of us are seeing that GI bleeds and lots of bleeds. They're not as safe as we think. And 20 to 25% of people in clinical trial do not take NOAC. NOAC trial, they don't take NOAC not for cost, but for some reason they don't tolerate NOAC. Yeah.
Praveen, you wanted to say something?
Actually, I just joined in, so I have not been able to hear Dr. Shetty's presentation, but certainly, he is the leading person
Pioneer.
for LAO pioneers, I must say, and then of course, hearing from him is always fantastic.
So great. Thank you, Ranjan. As always, you've been very precise. And like I said, you stayed away from the controversies. So I think I will just share my screen if I can. Complicated screen. So, can you hear me?
We can see your slides, sir. We can hear you.
Yeah, all right. Because I think Dilip is not a friend of mine because he gave me a tricky talk to do, and which is percutaneous options for severe tricuspid regurgitation. But it helped me look at a topic which is of great interest because I was involved briefly for one trick valve case a few years ago. And really, the paradigm appears to have shifted. So from being what was called in 67 as the forgotten valve, and very often we used to see these patients who would be operated by surgeons for other valves, so mitral and aortic valve, but nothing would be done to the tricuspid valve, and they would come back and they would be really, really sick. And all that you could do was add some more diuretics, and nothing more would happen. And for a long time, this disease was considered a mere surrogate for more advanced cardiovascular disease. The perioperative mortality risk, if you were to take these patients for individual surgery, now, especially post-operatively, was too high. And this was a condition which we always used to think, oh my God, what is it that we've done? Poor guy, look at this patient, he's suffering. The prevalence is not low. We may think it's 0.5% of the cases, but really, a lot of these patients have functional tricuspid regurgitation predominantly because of left heart disease, maybe mitral regurgitation, maybe poor LV, maybe some people who have primary right ventricular disease or who have rarely a carcinoid syndrome. But there can be hypertensive pulmonary disease, people who have pulmonary arterial hypertension. The combination of mitral regurgitation and atrial fibrillation can definitely cause tricuspid regurgitation. But what we have noticed over a period of time now is that a lot of patients who do have pacemakers will also get tricuspid regurgitation, which will increase in severity. Now, this will increase the RV failure, which happens because of tricuspid regurgitation, will result in tricuspid annular dilatation, which becomes progressive. It's a vicious cycle. And if you look at it, about 50% of people who are going to have left-sided heart disease, few of them are going to be pulmonary hypertension, a few of them are going to be organic, and less than 2% are going to be congenital. The prognosis we know is dismal because these patients really, really suffer. And it does not, the functional tricuspid regurgitation does not go away just because we treat the left-sided heart failure. For example, if somebody's got mitral regurgitation and tricuspid regurgitation, for many years, the surgeons told us, don't worry about the TR. I will fix the MR and the TR will go away. It does not go away. And if you are to take this patient back for surgery later, the in-hospital mortality is going to be about 10%. And these are the patients who get operated just too late to survive. So we may think that we need an interventional approach to tricuspid regurgitation to decrease the mortality and to be able to do better for our patients. Sorry. So there are many challenges in trying to understand tricuspid valve regurgitation. The first is how do you classify it? How do you diagnose it? We used to think of it as 1 plus TR, 2 plus TR, but we know now by using PISA and by using 3D-TE and by using three-dimensional echocardiography, we can classify it not only as mild, moderate, severe, but massive and torrential. We need to understand the tricuspid valve, the right ventricle and the pulmonary artery relationship, and we need to understand a lot of things. Yes, as interventionists, we'll say there's no left side of the heart, there's no aorta, there's no stroke risk, and it's unlikely that this is going to require a left heart catheterization for the procedure. But there are going to be difficulties in imaging the tricuspid valve because you can't do an off-face imaging. The challenge is that unlike the mitral valve, which is well seen on a transesophageal echo, this is a valve which is difficult to even image. You need a deep esophageal or a transgastric view. You may need a multi-window approach and a 3D-TE, which is online, and it becomes kind of difficult and challenging to actually even image these patients. So if you can't image the patient preoperatively, you can't use CT, you can't understand the tricuspid anatomy, you're not going to have it easy. The annulus itself is D-shaped. The composition of the tricuspid valve itself is heterogeneous. There is an asymmetrical dilatation, and only the dilatation of the septal segment is limited. But if you understand the anatomy, the number of leaflets are much thinner than the mitral leaflets. The number of leaflets is variable. We may think of it as 3 leaflets, but very often you may have 4 leaflets, and the tricuspid annulus in severe TR actually becomes huge with a free wall dilatation. So you have dense chordae, you have thin and variable leaflets, and a large annulus. 40% of tricuspid valves have 4 or more leaflets. So this makes it very difficult to delineate universal anatomical landmarks. Normally, this tricuspid valve has 2 pupillary muscles, but you may have a third. And the subvalvular apparatus is very much crowded. When we look at the tricuspid valve, we must know what lies around. We also know the membranous septum, the right coronary artery, the non-coronary sinus of Valsalva is right here. And there is no calcium to provide scaffolding support. The angulation and repair in relation to the SVC, IVC is very tricky. So if there are pre-existing cardiac leads, it'll further compromise. So when the annulus does get dilated, it may actually be irreversible. So what we may need to do is we may need to intervene early. Now we have choices. If at an earlier stage, we may be able to get away by using an annuloplasty device. At a later stage, when the coaptation fails, we may need a coaptation enhancement device, but larger gaps may need something more because functional TR is largely due to RV and annular dilatation. We need 3-dimensional imaging. I'm not going to spend time on it because it just complicates matters in a short talk. And we may need a combination of echo, multi-slice CT and 3DT. We may need multiple views for planning as well as for doing in-procedure imaging. We have to match the treatment to the pathology because as the annular dilatation happens, there are gaps, intercommissural gaps which will appear. And if the prolapse is not too large, you may be able to grasp it, but larger amounts will not be graspable. So you have to make a complex algorithm. You have choices. Edge-to-edge repair can improve coaptation. Annuloplasty, where the annulus is something which has to be treated. And today we have a choice of orthotopic and heterotopic valve implantation, which are available. Again, there are many favorable and unfavorable conditions. So if we examine this landscape, it can get very confusing with a lot of difficult names, but primarily, if we look at it, coaptation devices, we had an elegant talk by Ramesh on MitraClip. The same MitraClip was used as a tricuspid clip, and there was data for it. Further, Edwards brought out the Pascal, which is a paddle spacer class Alfieri stitch, which is similar to the MitraClip, but has some advantages, which has a confident navigation, optimized leaflet grasping, and a unique centering capacity. And this has now been put to test with some amount of compassionate use indication. About annuloplasty, we have the TriCinch and now the Cardioband, which has now been used for tricuspid valve reconstruction. Only thing we have to know is that the right coronary artery is what is labeled, and so you have to actually make sure that this is attached at the level of the around the annulus. So what about the transcatheter tricuspid valve replacement? We had many choices, but the EVOQUE appears to have actually been a uniquely successful device because we went from Navigate, Lux, TRICARES, but the EVOQUE had some good results because as compared to only about 57% of patients who were clipped who had a 2+ MR in the EVOQUE trial, this had 96% success rate. And this is how an EVOQUE is kind of done. We've not even seen it, but it is something which can be compared. There is a trial comparing it to medical therapy, which has shown that it is distinctly better. And this was an editorial, I think, last month in JACC Cardiac Interventions, where said, what are the choices for severe TR? And they claim that orthotopic valve replacement is probably the winner because regardless of the fact that we have good data from the edge-to-edge and closure techniques in those places where it was the leaflet which was at fault, but the 30-day data from the TriScent trial and now the TriScent 2 has been launched has been very, very promising. So now we also know that the CLASP TR has good results with the Pascal, but the cases have to be selected carefully. And in the TriBand post-marketing study, you can think of using Cardioband appropriately. But just to make sure that you use the right technique for the right patient at the right time, and because the circle appears to have come a complete circle, because surgery began with replacements, it was followed by repairs, whereas transcatheter therapy have began by repairs and might end up with replacement. So just to complete, if you can't do anything at the valvular level, can you do something so that the ravages of tricuspid regurgitation are reduced? Yes, you can, and you can do by both in the SVC and IVC, because that is what is transmitting the venous pressure to the rest of the body. You can do heterotopic caval stent insertion, and this is using what is called CAVI or trick valve. There are two different, it's a bicaval valve with a different valve for the SVC and IVC. These valves can go up to 43 millimeters of IVC, 37 for the SVC, and these are basically covered. These are like stent grafts with good valves, which need precise CT measurements at different levels to be able to size an appropriate SVC valve, an appropriate IVC valve. And once you have chosen it, you actually see whether the patient is anatomically suitable for this device, and exclude those who are not. And here is a case wherein it was actually here is the SVC valve being deployed, and if you go on, I think there is a shortage of time, but you can go on and see that then the IVC valve is deployed, and this will only thing is the challenge is that the IVC valve has to stay clear of the hepatic vein inflow. So all this comes in the CT when we are taking adequate measurements, and we need to make sure that we are not obstructing important venous outflow at any level. And this is, of course, in the same patient. What you can see is that this patient did show improvement, and after deploying the bicaval device, you can actually see that the patient had a decrease in the venous pressures. So this is the IVC stent being opened, the SVC stent is there, and you can actually see that the transmitted pressures have decreased remarkably. But one must understand that severe TR is actually the end of the spectrum, and one has to be careful that one must not conduct exercises in futility, and one must choose the candidacy for TR correction should not be based only on the severity of the tricuspid regurgitation, but should be determined by assessing tricuspid regurgitation, right ventricular function, pulmonary hypertension, and also the sequelae. It is said that gamma GT may be even more sensitive than using SGOT, SGPT, or even NT-proBNP. And usually these patients have all received sacubitril valsartan, have all received adequate diuresis, but still have ascites, maybe having advanced liver disease with cirrhosis, which may render this treatment futile. So functional TR is not uncommon. Majority of patients are not being offered any therapy. Current guidelines identify a high-risk group of patients. Transcatheter options may be impactful, but we need to choose the right option. Increased physician and patient awareness is essential, and we need to do this early, because if we do it late, it may still be futile. I hope I finished in time. If there are any questions, I will stop sharing and take them.
Thank you, sir. It was absolutely terrific. And could we have comments from Dr. Swami, Dr. Chandra, Dr. Kali? Otherwise,
Praveen, I heard that you have done a few tricuspid interventions. Can you tell something about it, your experience? Have you put, like Ramesh, our good friend, Mitra clip in the tricuspid position? Though we don't know that, we know that we don't do Mitra regularly, but in a few cases also, have you tried? I heard that you have done a few tricuspids.
Okay, yeah. So we have done several tricuspids now. And in fact, all of them were actually the trick valve, because the tri-clip, the Mitra clip is still not approved to be used in tricuspid regurgitation in India. Although we tried a few times to do it on a compassionate basis, but we were not able to get the device. So we had to resort to only the trick valve, and trick valve now it has become very simple. Now, no more we use, as you saw in Dr. Dhal's case, the transesophageal echo. We don't use transesophageal echo, no GA, nothing. So this procedure is very, very simple. Takes about half an hour only because it's a venous procedure. Patient is conscious, and we deploy the first valve, and also positioning has become much easier. So when deploying these valves is not so difficult. Protecting the hepatic vein again is not so difficult, because in most of these patients, actually the hepatic vein is almost half the size of the IVC. So there's not a big problem. So I think, for these patients where there's nothing else left, I think it's a reasonably good idea.
Terrific, Praveen, terrific your experience. And we'd like to see it in our next, you keep 24th and 25th of July vacant so that, we can see it. You're doing a tricuspid intervention live in box, okay?
So the game changer is going to be the evoke valve. The game
24th, 25th, yeah.
The game changer is going to be the evoke valve, because that the results are so good. Only the global numbers are so small as yet, but the results are really very awe-inspiring. So, and that is going to act at the valve itself. Therefore, it's going to protect the RV and the RA from the ravages, which unfortunately the trick valve does not worsen. I mean, it actually worsens what is going to happen to the RV and RA.
So what is your experience, Praveen? Have you the same experience what Anil is telling, that the RV and RA gets worse?
The thing is that it takes a lot of time to do that, because we have been using it for the last, almost 2.5 years. And we didn't see any deterioration in that sense, because the RV and RV were already, it was like they were having torrential TRs for a long time. So in fact, these patients became very well. One of these patients was so bad, we couldn't treat the edema, and this edema went away so quickly. So symptomatic relief is something which we are looking at this time, and it really helps.
Great.
In the interest of time, can we move on with the next presentation?
Yeah,
all right.
Sure.
It's my proud privilege to introduce one of the brightest young people I've ever worked with. And we're very, very, very proud of him. Is Ajay Swami, and he's going to talk to us on devices and paravalvular leak management. And over to you, Ajay.
Thank you very much, sir. Am I audible?
Yes,
very much.
Thank you, sir. Before I begin, my salutations to my teachers, some of whom I see here and some of whom are not. Sir is always a tough act to follow, but we'll do our best. It's my difficult brief today to talk in the next 10 minutes on post-valve replacement paravalvular leak and how do devices help. This is an image which I commonly use when I use the paravalvular leak presentation. You can look at this picture, and I'll come back to it at the end. There are actually two tigers on the screen, one that you can see and one that I'll show you at the end. We'll look at a case, a 47-year-old lady, 8 months post-DVR with worsening dyspnea for the last 1 month, gone from class 2 to class 3 with intermittent palpitation, mild parallel, little bit of icterus, prosthetic valve clicks heard, but a 4/6 murmur at the apex. A little bit of anemia, and it is indirect hyperbilirubin. She's got AF with fast ventricular rate, and this is what her transesophageal echo shows. You can see that alongside, this is post-DVR. So between the aortic and the mitral valves, you can see a jet of regurgitation, which is between these two valves.
Ajay,
your slideshow is not on. Please put your slideshow on.
Is that okay?
Yeah, that's better.
So then I'll just go back a little bit. This is a 47-year-old female, 8 months post-DVR, who presented with worsening dyspnea, parallel icterus on examination, mild anemia, hyperbilirubinemia, AF at fast ventricular rate. Is the echo visible now? Is the echo visible now?
Yeah.
Thank you so much. So I'm so sorry for that little glitch.
We kept looking for the tigers. You misled us. So that's
okay. So here comes the tiger. There are two tigers on the screen, and we'll come back to it at the end. So the leak is between the aortic and the mitral valves, and both of them are prosthetic. This is what it looks like on the 3D echo, and we'll come back to it later. And this is what we had finally: hemolytic anemia caused by the paravalvular leak and a little bit of pulmonary hypertension. This is the second case, 65-year-old post-MVR, 3 months with a murmur, and this is what her echo shows us. This is the leak from the lateral side, right next You can see the jet going off up to the LA appendage in the circumflex right there. This is the third case, another post MVR, 4 months. This patient has a leak from both sides, both from the aortomitral segment as well as from the lateral wall. Paravalvular leak is seen in about 5 to 17% of post-valve surgery. Only 1 to 3% of them require repair or intervention. But these patients are extremely sick. The definite indication for intervention is heart failure, hemolytic anemia, pulmonary hypertension. Untreated, their 3-year survival is only 65%. This in a patient who's already got anticoagulation on board and is post-valve surgery. And in case they're operated again, they have up to a 10% operative mortality. So this is a subset which is quite a sick subset, and we need to do something about them. Whatever we do is going to benefit them. Now, how does this occur? This is because of disruption of the sewing ring sutures or technical factors, tissue friability, annular calcification, infection. These defects are crescentic, oval, or roundish shaped. The track could be parallel, perpendicular, or serpiginous. The point I'm making is that they're very, very heterogeneous. Each patient is different. Each mechanism is different. Each anatomy is different. The management options, as we've discussed, are either a resternotomy, a percutaneous closure, which has a 2A indication, which could either be transseptal, retroaortic, or transapical. Now, the contraindications for percutaneous closure of paravalvular leaks are any indication for a classical valve replacement in case some other mechanical complication exists because of prosthetic valve instability, which must be ruled out. The requirement for a CABG, so the patient is going to undergo a bypass anyway. The presence of active infective endocarditis, which makes it extremely difficult and dangerous to place in any devices in such patients. Unexplained elevation of inflammatory markers for the same reason. And in case this is there, probably a whole body PET to make sure that there is no endocarditis is mandatory. These are oval and elliptical orifices commonly, usually have complex roots, and the size and length must be accurately measured, ideally on a 3D transesophageal echocardiogram. Now, this is how we conventionally, one group of interventionists uses this clock face mechanism or clock face nomenclature to call, with 12 o'clock being between the aortic and the mitral for whichever valve, and 6 o'clock being the opposite, and everything named in between on the NFAS view on the TEE. This is a more commonly used technique wherein the defect is actually named according to the anatomical structures which are around it. Most commonly posterior anterolateral if there is an LA appendage occlusion, LA appendage as far as the mitral valve is concerned. And in case it's the aortic valve, posterior is the mitral valve, the interatrial septum, and the aorta on the other side. Now, what did we do for our cases? As we've seen, this is where the leak was from, between the aorta and aortic valve and the mitral valve. That's where the leak was from. Now, transseptal was a possibility, but the distance between the interatrial septum and our leak was extremely small, and it would have been very difficult and a very, very acute angulation for us to deliver any device beyond that and to deliver it right across. We would have had to snare it to do something else. Retroaortic was not possible. The patient had an aortic valve in place already. Transapical was the route that we chose because this was simpler. This is where we would have easily reached our location of leak, and that's what we did. It was a straighter route. These were the devices that were available. And since it was an elliptical defect with a high flow, we chose an AVP3. Now, this device is not available in the US, and we had some difficulty in making it available. But when it is an excellent option because it's oval and elliptical, and you can actually orient the long axis along the long axis of the leak by using small, simple indicators, using the side on which the flush sheath of the sheath comes off, the flush valve of the sheath comes off, or the back end where you can put in the screw in for unscrewing the device. That can be the indicator of the long axis of the device. The Occlutech paravalvular leak closure device has been developed only for paravalvular leaks, but is not yet fully available as far as we are concerned in India. The target is complete occlusion with no embarrassment of valve leaflet movement, with a stable and a fixed position and no possibility of embolization. We did it under general anesthesia with 3D TEE and a 23 centimeter long 7 French sheath. This is what was done. The LV was opened. You can do a direct puncture as well, but sometimes you hit an epicardial vessel and then that becomes an additional complication to sort out. The puncture faces slightly more posterior so as to reach the mitral valve easily. Place a short sheath in the LV and then next cross the paravalvular leak under TEE guidance with the Termo wire. That's what we did with an 0356 French Termo sheath. This is what it looks like on the 3D TEE. Exchange that with an 035 normal length wire, put in a 23 centimeter sheath across the defect, deliver our device. This is what we chose, the AVP3. And this is what it looks like when it's delivered from the sheath. We check on the 3D TE, pull it back right up to the defect. You can see the catheter through the defect with the AVP3 across. Bring it back up to the device, close, check that the valves are not embarrassed as far as movement is concerned. The hemodynamics is fine, and you can see that it's opened well. This is what it looks like when we do the TE, the 2D TE. The leak is almost gone now. You check on the angiogram as well. This is not so much for the contrast as because you see the leak much better when you inject the contrast on the TEE, and then subsequently release the device as we normally do. Pull the delivery sheaths back, and that's what it looks like on the 3D TE. The leak is completely closed, and the same thing. You can see the device here, and there's absolutely no leak across. It's completely closed. This is our second case, post MVR 3 months with a systolic murmur. Again, this patient, we chose a transseptal approach because it was the posterolateral part of mitral valve when it was far away and in the lateral wall near the appendage. This is what we did. This is a transseptal puncture done with in the middle of the fossa, closed or a little closer to the SVC because it's easier to cross. Then along with that, put in an Agilis sheath. Inside that, a JR guide with a Termo wire. You can see the wire will finally find the leak and cross. We come back with the wire, position it at the leak under the TEE, rotate the sheath, cross into the LV across the leak. Put in the device, put in the delivery sheath over the same JR wire with the Termo wire inside, then remove it. Just check that we're across the leak perfectly on the teeth. All this is done with live echo, 3D if possible, but 2D in this case. Put in the device there, close, perfectly perform the echo, and then release device on the right lower screen. This is what the echo shows at the end. It's been speeded up. I mean, that is a technical glitch. It's not actually as fast as it looks like. And that's what the device looks like in place, and it's completely closed. And this is the third case who had a leak from both sides, both from the aortomitral segment as well as from the 6 o'clock segment. So we first close one. You can see one device in place already. This is the first device that has been placed in the lateral wall here. There is a small residual leak because we weren't, this was also done transapically because we weren't able to release the cable completely. We pulled the cable back, put in the second device on that side, and that's it. Since this was a much larger one, we used a muscular VSD device on the opposite side and an ADO2 on the lateral side. And that's our final result. This is to show that the aortic valve is not at all embarrassed by this large muscular VSD device, which is there in between. Paravalvular leak is a difficult problem. Every anatomy is unique. The treatment options are only to be exercised if there is hemolysis, pulmonary hypertension, heart failure. Surgical outcomes for these patients are not great. Careful planning is the key. Ideally, whatever imaging one can use, it will help us, and always follow up. Small residual leaks may take a little time to resolve, up to 90 days, but most of them often do, and this is a very, very gratifying treatment option for these patients who are often very sick and cannot be left alone. This is just to show that the number of series is not very large. This is all the large series which have been reported, and the largest one is about 56 cases. This is our second tiger. If one looks carefully at the image, there's one tiger that you see, and if we concentrate on the body of the tiger, you see the second tiger written there, the hidden HIDDEN tiger written on the body of the tiger. Paravalvular leaks are often like that. They don't look like they're very bad initially, but our patients will pay for it if you don't close them when they're required. Paravalvular leaks is always teamwork: anesthesia, radiology, cardiothoracic surgery, the cath lab, the echocardiographer, and of course, administrative support in my organization is very important. Thank you for your attention. I should be glad to answer any questions.
Oh, brilliant, Ajay. So that was very well done. And I see Anil Singhi here, and maybe you would like to say something.
Yeah, very nice talk, Dr. Swami. Is nice to see your case series. My question: in the double valve, you put transapical. Do you advocate the transcutaneous direct transapical puncture and closing it off with a device coming off?
So I'm very fond of the transapical approach, and I've done it several times. The only problem is the surgical option actually gives you controlled access. Sometimes the wraparound LED, when one tries to hit the apex perfectly, we damage the epicardial vessel, and then we end up with an ugly hematoma or a little bit of leak into the pericardium. There is no issue about closing it with a device. So there is an option actually. One could do a CT angiogram and try to identify where the epicardial vessel is, but it's still not ideal. Having a surgeon give you a small little access is just another half an hour's job. Patient is going to be on GA anyway. It makes it absolutely safe, and he can close and come out. There's no problem. I've often closed with devices that I've shown. Dhal sir has seen so many of my dirty cases which were given, and I was very fond of the transapical access, but I think elective controlled access, it probably makes it just a little safer. That's all.
Praveen, you've done a lot of paravalvular leaks. Yep.
Okay, yeah, Anil, I think, this was a fantastic presentation, and Ajay Swami is really expert at it, I must say. And let me tell you, I was just doing transseptal in most of my medial and lateral cases. And we did, now we have done about 75 cases, and 74 of them are transseptal. Only one we had to do with transapical with the help of Ajay and Brigadier Naveen. I just discussed with them. I said, this is just not entering. So he said, but just go ahead and do the apical. So we did the apical, which was perfect. It worked out very well as he showed. But one thing is there, slightly different, that we always use the AVP2. And the usual size which should be available in the cath lab is between 12 to 16. And it is always better to oversize, because most of these actually leaks are centric in shape. They are not just like totally round. So if you use a bigger one, it works out quite well, because earlier we were using 2 or 3 at one time, because we keep the wire and keep pushing it and then release it all at the same time. So basically using a AVP2 is quite okay. It is easily available, but I think, AVP3 is a great idea, but it is not still available freely. And so I think, this technique is really helpful as work. It is very predictable. It is just first 5-10 cases. And then, in fact, what happens is I have, I'm getting a little bit, less trained in this now, because when I enter the lab, almost everything is done. We are just going to put the device, because my colleagues, my friends have already started the case and they have crossed this and everything is done. So basically it becomes, I'm just trying to say that it becomes very fast. Earlier it used to take 2.5 hours, but touch wood, now we just finish it within 1 hour most of the time. So especially when it's laterally.
That's, we improve our team effort. Like you said about trick valve, it used to be a 2.5 hour exercise. Now it's a 30-minute exercise. So the same way, only thing is that there are some choices in devices which are not freely available. Ajay mentioned Professor Hans Figula actually made the Oculotech device, which is ideally meant for serpiginous kind of paravalvular leaks, which may actually be very suitable if they were freely available. Dr. Bali sir, would you like to say something?
I think excellent talk as always by Ajay. Only thing is, previously it was done that you make a loop, snare the wire, and go over that and deploy the device through the paravalvular leak. But I saw all of the cases which you have done is integrate, and the sheath is passed into the LV, and then you deliver it. Any particular reason that one technique would be better than the other?
Sir, the devices that come for paravalvular leak closure are now extremely soft, extremely malleable, and very, very easily delivered. The only rate limiting step is the ability to deliver the delivery sheath. If one is able to get the delivery sheath across, putting the device inside it, if it is not, because we have got beautiful braided delivery sheaths now, they don't really kink at all. Earlier, the problem used to be that they would kink and then one would have to kind of release the kink, push it forward, pull it back, push it forward, release the kink somehow. That is why we needed the AV loops, etc. Number two, most of these are very, very friable. If one tries to put a very large sheath into a leak, we actually end up making a 3 millimeter leak into an 8 millimeter hole. And then we end up with a bigger problem. So there is an issue with it. That is why we favor the transapical access, because the requirement for manipulating is actually minimal. The leak closes extremely fast. There is absolutely no, trauma required to be done. With care, with a good echo, one can easily put the sheath exactly where one wants to, with the exception of the case that I showed, that when one has a transseptal and a large agilis sheath. Sometimes I use 2 axes if I feel that one device does not close, like what Dr. Praveen said. I will never deliver them try not to deliver them from the same one. I deliver one antegrade and the other retrograde so that I can deliver them both together. And I will leave the wire across. So that is just a technique, but that is individualized for that particular case. As far as the choice of the device is concerned, whatever is done on that day is fine. But I find that any device which has got a disc at one end is easier to manipulate, rotate, and fix exactly where. That's why we favor the ABB.
All right, Ajay, Dilip is ringing me up and telling me to go ahead.
Sorry.
So I think the game changer in this game was the ADO 2, because since that came, we did not have to start making these elaborate loops. So having said that, and I think we are now over to another great master. We're going to have Professor Bali, who's going to talk to us about a very complex topic, because we are all scared of it: coronary intervention in patients post-TAVI. And he's going to show us cases. So I don't know how many cases of TAVI he's had to do coronary interventions. And now he's going to tell us that he's used rotablators through post-TAVI patients, and he's pushed guideliners through there, and he's done complex bifurcation, trifurcations. Over to you, sir. We are going to watch the magic.
At the outset, I would like to say that I don't have too much experience about Tower. We're just starting our program. And the second thing I'd like to say that I only knew about this presentation yesterday. So I'm feeling like good old Jaisima, who was called on to Australia way back in 1967 to first go and play in the test match. And I also reminded of Ravi Shastri, who was called on by Gavaskar to New Zealand to start his career.
So both did very well. Both did very well. Jaisima, if I remember, hit many sixes, and Ravi Shastri got a 6-wicket haul. Right.
Starting from that cricket analogy. So let's say first case, and she's a 75-year-old female. She is a mother-in-law of a cardiologist. She had progressive dyspnea, angina. On investigation, found to have a severe aortic stenosis and severe left ventricular dysfunction. Left infection 26%, and she also had a coronary artery disease, a discrete stenosis in medallidy, and we decided to go ahead and do an angioplasty stenting on her, and then a Tower on the same day. This is the medallidy lesion. If you can see the lesion here, and that was a straightforward lesion, so there was no much problem there. We could do the angioplasty stenting, and then we went ahead and applied the Evolute aortic valve. She has been doing extremely well for the last 3 years. No paravalvular leak, no gradient. She's doing okay. Now, our second case is a 63-year-old male presented with complaints of progressively worsening dyspnea and abdominal distension, bilateral pedal edema, had severe aortic stenosis, left ventricular ejection of 30%, and right coronary was, there was a patent stent in RCA, and there was a discrete stenosis in LAD. And you can see the stenosis in the LAD. And again, this was done on the same day, and the angioplasty stenting was done. And subsequently, we went ahead and put in a Evolute valve. Again, rather straightforward, no paravalvular leak, and no gradient. She's doing well. Now, this is an interesting case which Dr. Praveen is here, and he was with us a few days back, and it was nice to have him. We had to make a lot of effort to get him here, but we got him finally here. So she's a 68-year-old female, a known case of hypertension, hypothyroidism, chronic kidney disease. She had previously undergone angioplasty stenting of circumflex in 2009, again had a angioplasty stenting of L6 ICR in 2011. She presented with progressively increasing dyspnea. On investigation, her EF was 58%. She had severely calcific aortic valve with gradient of 78 millimeter and a valve area of 0.7 millimeter. She had extensive calcification in the pericardium and mitral calcification. She was refused by the surgeon, and therefore we decided to go ahead and do evaluate her for transcutaneous aortic valve replacement. The CT angio showed that other parameters were great, but the left coronary artery height was only 7.8 millimeter. So before we started the case, we had concern that there could be some pinching of the left coronary or may get covered. So we needed to protect this left coronary artery during the angioplasty, during the TAVR technique. So we did our angiography, which showed that her circumflex had severe ISR. This is what it shows. So we first went ahead and did an angioplasty stenting of that. It took some effort because the stenosis was very hard and the balloon would keep on slipping. And there was a balloon-induced dissection, which was covered by another stent. And then we went ahead and started with a TAVR. You can see the left coronary system. The height of the left coronary is very low. And then balloon angioplasty was done, balloon valvoplasty was done. And then we decided to keep a guide catheter and a guide liner in the left coronary system and placed a stent in the mid-LAD in case the left coronary artery was pinched. We would be in a position to stent the osteo of the left main to the left system. So after balloon valvoplasty, this is a my valve, and that was taken. It was negotiated very nicely. There was no problem, and the stent balloon was inflated. Stent was deployed, and we had some paravalvular leak, and then we dilated with a bigger balloon. And after that, the paravalvular leak completely disappeared, and we had a gradient of only 6 millimeters. So that is when we started wondering whether the left coronary has been pinched or not. We took multiple angiographic views, and there was doubt about whether it was pinched or not. We couldn't decide on that, but the decision came from transesophageal echocardiography. On transesophageal echocardiography, it was seen that the left main, which we had showing normal flow initially after we had deployed the stent of the valve, but when we post-dilated, there was some, you can say, translucency there at the origin of the left main coronary artery, and that was causing concern. There was no hemodynamic problem. ECG was fine, but both Parveen and me were concerned about this left coronary artery, and the transesophageal operator was very keen that there was definite difference between the first T and the second T. So we decided that we go ahead and put in a stent there. And cross that again because we had withdrawn the guiding catheter. It was easy to cross. This is angiogram, which you see. Actually, it's very difficult to say whether there's pinching or not. So we took a decision based on definite finding on transesophageal echocardiography. So placing this stent was not tough. This is a 4 into 15 millimeter stent. It was post-dilated with a 5 millimeter stent at 18 atmosphere. And then we had a normal flow, and T showed that there was a good flow. And she has been discharged today, and she's doing very, very fine. No problems. So that is in addition to doing coronary angioplasty stenting in this case, we also had to do a left main stenting for protection of the left main coronary artery, which we had anticipated by looking at the CT angio. So evaluation by CT angio is extremely important. Now coming to coronary artery disease in patients undergoing TAVR, and incidence is variable. And if you look at different series, it's variable from 40% to as much as 80%. And those patients who have outcome when they undergo TAVR, so we need to look at how to tackle this coronary artery disease in patients undergoing TAVR. And it's been seen that those patients of coronary artery disease who require hemodynamic support have a higher mortality than those who do not require hemodynamic support. So we need to take care of coronary artery disease either prior or at the same time or subsequently once you're tackling TAVR. Now, how do we decide it? Now, if we have a coronary artery disease which is left main, or it is showing ischemia, or there is a multivessel disease, then obviously coronary artery needs to be taken care of. And it also depends on how critical the aortic stenosis is. And obviously, if there is a single vessel disease or myocardium at risk is not too much, then we can reevaluate and see those when to tackle the coronary artery disease. Now, there are definite advantages and disadvantages of tackling coronary artery disease prior to TAVR. The first thing is it's a simple procedure before TAVR. There's a less ischemia and hemodynamic instability during rapid pacing and balloon inflammation during subsequent TAVR. And we minimize the dose of contrast which is used. And it's been seen that that is the preferred technique in most of the centers. But the disadvantages are that we are using dual antiplatelet drugs, and that would add to, may add to bleeding during TAVI. And this procedure has been followed. Now, combining both the procedure, PCI and TAVR, the advantages of that are obviously both the pathologies have been taken care of at the same time. And we need a one arterial access both for PCI and TAVR. And we also probably reduce the risk of inducing ischemia and hemodynamic instability while performing TAVR. Now, disadvantages are increased duration of procedure, increased contrast load. These patients are critically sick and may have nephropathy added to that. But when we choose a PCI and TAVR at the same time, do we choose PCI first or TAVR first? And most of the time, it would be PCI first and then go on and do TAVR. Now, if we look at meta-analysis of PCI and TAVR together, we find that when we do both PCI and TAVR, it definitely favors isolated TAVR would have better results as far as mortality rates are concerned, as far as rates of myocardial infarction are concerned. The bleeding rates would also be less, and access site complication would also be less, as would be renal failure and stroke and TIA. Now, PCI after TAVR, the advantages are that PCI risk is lower after the aortic stenosis has been fixed up. And the disadvantages is TAVR in the setting of ischemia may be risky. Now, access issue is the biggest problem, that once you are put in a TAVR, how do you access the coronary arteries? And this could be a problem in self-expanding valves particularly. Right? Increases the fluoroscopic time, radiation dose, and contrast also. Now, there have been cases in literature where the catheter has been caught in a stent frame, and in fact, one of these patients died. And if you look at what are the factors which impact coronary access after putting in a valve, one is the sinotubular junction dimension, sinus height, leaflet length, sinus of valsalva width, and coronary height. So those are the factors which determine whether we would be able to access coronary artery after putting in a TAVR or not. And these days, we can use a guide liner very, very commonly in these patients after crossing the frame with a wire, and that would give us access in accessing the coronary artery. So technically a little challenging, but can be done. And this is how we go about it. And we cross with a wire, and then if we are above the skirt, then we can easily access the coronary arteries. But otherwise, we can use a guide liner to access the coronary artery and go ahead and do angioplasty stenting on that. Similarly, after Edward also, we can use a guide liner to access the coronary artery if the access is difficult by the routine guiding catheters. If we can go from above the valve, that would be much easier, but we can cross through the struts and enter. You may have a little difficulty accessing the guide, but with using a floating guide wire and then a guide liner, the technique would become simpler. But definitely more contrast would be required. So what are the factors which lead to predisposed to coronary obstruction after we put in a TAVR? One would be deficiency of sinus of valsalva, low sinus of valsalva, narrow sinotubular junction, and low coronary ostium, as we saw in the case which we described. And if we have a bulky leaflet mass, that would also obstruct the coronary. So how do we go about tackling these patients? Now we do a coronary angiography. If there is obstructive coronary artery disease, we see how much is the myocardium at jeopardy. If there's a severe coronary artery disease, we go ahead and do a coronary artery angioplasty stent. If there's a moderate coronary artery disease, we'll go ahead with a TAVR and then subsequently reevaluate to see by non-invasive technique to see the need for angioplasty stenting. Now, if there's a small area of myocardium at risk, like the distal vessel or a small vessel or a CTO, we do a TAVR first and then ischemia-driven revascularization. Obviously, when there is no obstructive coronary artery disease, TAVI alone would be the treatment of choice. So to conclude, there are no definitive recommendations on how and when to treat coronary artery disease in patients undergoing TAVR. Most of the people would prefer to do a coronary artery disease if it is large myocardium at risk, our patient is symptomatic, and PCR and TAVR in the same city with a PCR preceding TAVR would be the treatment of choice, but PCR can easily be done after TAVR as well in most of the cases. Thank you. Thank you very much. Anil.
So thank you so much, sir. It was a brilliant presentation. And Dr. Dr. Dhal has lost his network. So may I request chairpersons, Dr. Niman Kali, Dr. Praveen Chandra, Dr. Swami to have any comments. Otherwise, move on to the next session.
Brilliant talk, sir. Just one little, we've been doing TAVR for some time. We have actually stopped doing TEE. So, we've stopped doing TEs along with TAVR. So is it the practice to still do TE? I mean, any patient with low coronary height will always protect, and it was demonstrated very beautifully. We'll always place a guideliner inside, because trying to protect it without a guideline is fraught with danger actually. But it's extremely interesting that the TE helped you make the decision. I think it was great. Did you put it before or we put it after?
I think we have, whatever cases we have done under TE as of now. But as I said in the beginning, the journey is just beginning. So there's a lot of ground to be covered. So I thought initial cases TE would be good. Praveen, your comments?
I think, TE was, in this particular case, was used from the very beginning because the patient was done under general anesthesia. So whenever a patient is under GA, it is absolutely reasonable to have the TE rather than doing a transthoracic. And also one very important indication of TE still is those patients where the chest wall is not good. You don't get...
Hello.
Sir, we lost your speech. Praveen, sir, you are muted.
So I was just saying that, we still use TE in some cases, especially in those where a general anesthesia is being done for the procedure. Number two, in those patients where the anatomy is not very conducive, not very good, and the chest wall is not good. So if you don't do good transthoracic images, and this happens in many patients because many times they have COPD, the chest is fully expanded. So then we use a TE because we have to make those decisions at that time. And if you don't have especially a TE, you can't do that quickly. So that is why we still use TE, but otherwise 90% cases we don't do TE, no GA, nothing. But we have to be still careful. And in this patient, this helped. This thought process actually helped because the coronary was low. The sinus was borderline because this was a 26 valve. We had the plan to go with 2 cc or 3 cc extra, which means that the valve will go up to 27, and which means that the space will be just 1 centimeter.
So the sinus was very small, sir. Perfect.
Very small. So that is why we took this precaution. And then when we were checking we did a balloon aortography also, which was with a 23 size balloon, which was small. And then we did, we found that the flow was good. And then after the stent implantation, the flow was there, but the leaflet had moved quite close to the left main, which sometimes we have seen patients can have sudden collapse after 1 day or 2 days because thrombus starts there. So that is why.
No, sir, we would have probably done the same thing. And looking at the anatomy, we would probably have stented the left main as well. Only the TE is something that we don't do unless, as you say, we stopped using GA. We're just using conscious sedation most of the while. We don't use the TE anymore because it's a quick procedure. You really don't need so much. But that's a learning that maybe the left main flow is, if it's there, you can use it. That's fine. But very often we don't have it. So that is something that we should think about. Great learning, sir. Thank you. Thanks, Bali, sir.
Thank you.
Super.
Thank you, sir. And with this, I think we'll have to conclude the penultimate session because we are running out of time. I thank the chairpersons, the moderator and the expert panel for a very enriching experience.